My lecture is on the evaluation and treatment of sports injuries to the lower extremity. Financial disclosure, I did not receive any outside funding or grants in support of the preparation of this presentation. So what we're going to talk about is we're going to talk about the difference between the classic or low or lateral ankle sprain versus a high ankle sprain. First off, who's in this room? Physical therapist? Raise your hand. Okay, so most of you guys athletic trainers? Okay, good. We're also going to talk about the Lisfranc injury. Who's heard of the Lisfranc injury in this room? Okay, so most of you guys. And we're also going to discuss turf toe. So first, introduction to the ankle injury. 25% of all athletic injuries involve the ankle. 40% of ankle sprains have the potential to create chronic problems. And kind of like Dr. Weber alluded to earlier, how often do we hear it's just a sprain? Because there's a big difference between a low ankle sprain and a high ankle sprain, and the return to activity is quite different. Mechanism of injury. Lateral ankle sprains occur from an inversion or internal rotational force applied to the foot while the ankle is in a plantar flexed position. When you evaluate these patients, there are biomechanical abnormalities that can lead to patients further exacerbating this condition, like a high arch or pes cavus, like a rigid rear foot varus, like a plantar flex first ray, and some other modalities. So by doing a comprehensive evaluation, we can put little things in their shoe like orthotics or ASOs, ankle stabilizing orthotics, to help prevent these injuries prior to them actually happening. So there are programs out there that do evaluate all the patients prior to initiating activity. A little bit of anatomy. The three major ligaments that we look for with a lateral ankle sprain are the anterior talofibular ligament, which is the most commonly injured ligament with a lateral ankle sprain, followed by the calcaneofibular ligament, and then lastly, the posterior talofibular ligament. Incidence. Basketball ranks number 1 with the highest reported lateral ankle sprain injuries at any level. It's due to the constant nature of the game, shuffling, lateral movement, pivoting, penetration. All those things do play a key. It's important to know that athletes often return to full activity at a quicker rate with this type of injury than a high ankle sprain. Evaluating a lateral ankle sprain. There are a lot of other injuries that can be associated with the lateral ankle sprain, such as a fifth metatarsal base fracture, osteochondral defect or talar dome lesion, peroneal tendon injury. There's a plethora of things that we need to evaluate. But one of the things that you'll often see is lateral edema, ecchymosis, and palpable pain. The two clinical exams we do is called a Taylor tilt test, which we evaluate the integrity of the calcaneofibular ligament. I'm going to show you guys some x-rays in which we actually do this under live fluoro so you guys can actually see the difference between a pre-evaluated and a post-evaluated ankle. And lastly is the anterior draw test. It evaluates the integrity of the anterior talofibular ligament. This is the most commonly injured ligament that you guys will see. And like I alluded to earlier, there are other injuries associated with a lateral ankle injury. And this is kind of my quick 7 things that I test really quickly in order to make sure that I am just dealing with a lateral ankle sprain, or am I dealing with something more complex or a concomitant injury such as a fifth metatarsal base, or a peroneal tendon injury. So we're looking at a lateral ankle film. See the tibia, the talus, and the calcaneus. Pretty good at tibio-talar calcaneal angle. No real abnormalities. When you stress it, you try to bring the foot towards the examiner while stabilizing the tib fib, you can see the gross displacement that you notice at the tibio-talar angle. That is an indication of an anterior talofibular ligament injury. This is not commonly performed in an office setting in an acute type of sprain because pain. It's very tough to anesthetize a patient to the point where they'll actually tolerate this type of testing. So this is often done either intraoperatively or under sedation. Next is we're looking at an AP film of the ankle joint. You can see pretty normal, nothing too terrible. But once you stress it, you can clearly see the obvious defect in the calcaneofibular ligament. So stress radiography in sprains is important, but it does have its limitations due to patient pain intolerance. Classification systems, grade 1, grade 2, grade 3. I typically use these as A grade 1, I typically associate with an anterior talofibular ligament injury. They're going to recover quicker under the 4-week realm of the injury. A grade 2, you pretty much say right at 4 weeks, and a grade 3, potentially 4 to 6 weeks. So treatment. A lateral ankle sprain without the associated osteochondral defect, without the peroneal tendon injury, without the 5th metatarsal base fracture, respond very well to conservative treatment. But you got to use evidence-based approach in order to get predictable and functional outcomes. Typically, I'll put a patient partially weight-bearing in a cam walker for 2 to 3 weeks, and then start to initiate range of motion. One of the biggest things that I find here that drives me crazy is patient compliance. Because when you tell them, you didn't have a fracture, you sustained a sprain, they hear, this is not a bad injury, I can go back to wearing regular shoes in 2 to 3 days. And if not, if you don't take this injury seriously, you can have a lot of unfavorable outcomes. In the event that conservative treatment fails, we often do take these to surgery. The 3 most common reasons why is 1, chronic lateral ankle instability, someone who sprained their ankle 5, 10, 15 times. Others are the elite or professional athlete with a grade 2 type injury, a la Kyle Korver, point guard, Atlanta Hawks, just had this surgery performed. Or an acute injury that's failed immobilization, that's failed physical therapy, that's failed non-steroidal anti-inflammatories, or elevating or compression and the such. This is a picture of the case that we did where we're actually utilizing a suture anchor to repair the anterior talofibular ligament. The ATFL is actually embedded within the ankle joint capsule, so it's important that you get large bites. And I use a suture anchor to reinforce that to the fibula or towards original attachment. And then we go ahead and just run a few Ethibond stitches and repair the anterior talofibular like so. Post-operatively, big difference between a non-operative ankle sprain. So first 6 weeks, strict non-weight bearing 3 weeks. Then we gradually introduce partial weight bearing 3 to 6 weeks. So you can see that it's 6 to 10 weeks is when we send them to you guys. That's when we initiate the partial or the range of motion activities, not quite full. I go about 75% of full activity, and then 10 to 14 weeks is when we really get on it. We often use an ASO or an ankle stabilizing orthotic to help with that, but ideally at 14 to 16 weeks, the patient should no longer need a supportive device, and they should be able to return to sports. So that is my goal with a surgically repaired ankle, 14 to 16 weeks. High ankle sprains. Extremely difficult to, 1, diagnose and treat effectively. You are much more likely to develop chronic problems with a high ankle sprain than a low ankle sprain, most commonly due to PTA or post-traumatic arthritis. This does require a much longer recovery time. In fact, studies have shown that it takes about twice as long to recover from a high ankle sprain than a low ankle sprain, and not a lot of people know that there's a true difference. So it's important that educating family, educating the coach, understanding that this is not just your typical sprain. So the high ankle sprain mechanism of injury. It's an external rotation of the foot with a traumatic internal rotation of the leg. This does require significant force. You typically see this with contact sports like football, hockey, soccer, things like that. You don't see this often as like a basketball injury or something like that. That's not as physical. A little bit of anatomy. The anterior inferior tibiofibular ligament. Oh, sorry. Right there, that is the most commonly injured ligament in this type of injury. Next, you've got the posterior inferior tibiofibular ligament. It's got a superficial and deep component. This is your strongest ligament that is rarely damaged. You really have to do some damage in order to damage this ligament, and this is what essentially helps keep that joint intact in the event you do have a high ankle sprain. And there are times that do require surgical repair in which that posterior inferior tibiofibular ligament is aiding in that bind between the tibia and fibula, and not causing just frank diastasis or widening between the two bones. So having that ligament intact is imperative to success in this injury. And lastly is the interosseous ligament. Interosseous meaning between osseous bone. It's about 0.5 to 2 centimeters proximal to the talotibial disarticulation. This is kind of where we aim when we're actually doing a syndesmotic repair with a screw or with a suture anchor in the event it is severe enough to require surgical intervention. So like we talked about, internal rotation of the leg goes this way, foot goes that way. This is your stress point separation. So in an injury, in a high ankle sprain, like I said, the anterior talofibular ligament is ruptured first. It contributes 35% of the syndesmotic stability. Next is the interosseous ligament. That is the second most commonly injured ligament, which contributes 22% of the structural integrity of the joint. So if you rupture those two, you're already over 50% instability of the ankle. Incidents like we talked about, most commonly seen in contact or collision sports like football, soccer, rugby, these have a high degree of variability, meaning that there are a lot of times an associated fracture, most commonly the fibula, that you see with this. There's a very common ankle fracture classification system we use called Log-Hansen. And anytime you have a supination or inversion type injury, this is often the first, step or stage of that injury. So physical examination, we use the squeeze test or the intraoperative cotton test. Physical examination, you manually compress the tibia and fibula together, stressing the anterior and anterior talofibular ligament, which will cause intense pain. And then intraoperatively, this was a case that we had where there was a significant diastasis between the tibia and fibula with a concomitant fibular fracture. Once you repair the fibular fracture, you take literally a hook and you pull the fibula that way to see if there's any diastasis or separation between the two bones. If there is, we go ahead and put 1 or 2 syndesmotic screws across to hold those ligaments intact. And lastly is the stress abduction test. You forcefully abduct the foot away from the body's midline while maintaining the foot, or leg rather, in the frontal plane. It's key. This is a very easy test to mess up because if you keep the patient with a straight leg, the gastrosoleal component can actually prohibit or diminish some of that abduction force and give you a false positive or false negative report. So it's important that you keep that knee bent. Obviously, it doesn't have to be to 90 degrees, but it's best served at 90 degrees to completely eliminate the gastrosoleal complex. This is radiographic examination. This is us looking at the AP view again between the tibia and the fibula. Less than 5 millimeters is a normal radiographic finding. A widened mortise is what you see with the classic high ankle sprain. The problem that oftentimes we see is these are obtained non-weight bearing, whether it be in a critical setting like an urgent care or an ER. If they've got pain, chances are they're not taking weight bearing images. Without a weight bearing image, you're not going to see the stress on that joint. So I can't tell you how many times patients come to my office saying, oh, I went to urgent care over the weekend, they said there was nothing wrong, yada, yada, yada. 3 weeks later, they're still in pain because they didn't have the proper examination performed. Next is medial clear space. Less than 4, normal. Greater than 4, abnormal. So, like we talked about, radiographically, weight-bearing images are key. And oftentimes they're not always this obvious. You're not always going to see the increased medial clear space. You're not always going to see the associated fibular fracture. And a lot of times, if I see this and a patient has no pain along the lateral ligaments, and I don't really notice any increased medial clear space, you have to get a tib-fib view of the leg. Have to. Because oftentimes you'll see a non-displaced fibular fracture here, which will indicate that there is a syndesmotic injury. And how you fix that is not with the plate and screws up here, it's with repairing the syndesmosis down here. Stress radiographs, again, very important, difficult to achieve in an outpatient setting due to pain, but if you're ever in doubt, stress it. Treatment, high ankle sprains. Without gross diastasis or widening of the tib-fib joint, respond relatively well to conservative therapy. Rice therapy. The big and key difference in my treatment protocol with the high ankle sprain versus a low ankle sprain is that 100% of the time, I will immobilize a high ankle sprain for 2 to 3 weeks. Compliance is so critical with a high ankle sprain that I just, like Dr. Weber said, he doesn't trust any of his patients. I do not allow a patient that I suspect has a high ankle sprain to step foot on that foot for 2 to 3 weeks without constant reevaluation or stress viewing the ankle under radiograph. After that, we do get them into the partial weight bearing 2 to 3 weeks, but as you can see now, you're almost at 4 to 6 weeks without any range of motion, whereas with a low ankle sprain, you should be getting some range of motion about 2 to 3 weeks. And education. Education is so critical to the parents, to the coaches, because they think when they hear sprain, it's not bad, they can return to injury relatively quickly. Other options that you have, there's an iWalk free brace. This is a company based out of Canada. The other is a total offloading anti-gravity device brace, or a TOAD brace. And lastly is an instant total contact cast, which is basically a cam boot wrapped with fiberglass so the patient can't take it off. Anytime you want to improve patient compliance, you have to save the patient from themselves at times. So how do you fix it? A high ankle sprain, if you have 1 millimeter, just 1 millimeter of lateral displacement of the fibula that decreases the tibio-talar or ankle joint contact by 42%. So what does that mean? It means that you now have an abnormal ankle joint, which every step you take, when you are walking, it absorbs your normal weight. When you run, you can literally carry up to 10 times your body weight. If you have an athletic person who's doing 5, 10, 15 miles a day, they're going to increase their chance of developing post-traumatic arthritis of the ankle joint and literally, potentially end careers. How do we fix it? You can either use a suture button across the top, 1 to 2 centimeters proximal to the tibio-talar articulation, or you can use a screw. Post-op rehab, non-weight bearing whatsoever for the first 6 weeks. After 6 weeks, you begin a protected weight bearing protocol. Again, 6 weeks is pretty much my magic number when dealing with surgical ankles of the low or high, in which we get physical therapists, athletic trainers, things like that involved with the treatment protocol. At 12 to 16 weeks, if the syndesmotic screw is prominent or it's bothersome, we will take that out. Once we take that out for those 2 to 3 weeks, we only want linear motion, because there is a chance that with that screw removal, you can again get some instability at the ankle joint. So once we're confident, 2 to 3 weeks after that surgery of the removal of the syndesmotic screw, that the patient can undergo lateral motion, that's usually when we initiate the return to activity. The Lisfranc injury. This was named after Dr. Lisfranc of the Napoleonic Wars. With this type of injury, you saw it a lot of times with soldiers that were on their stirrups that would fall out and have a forceful abduction of the foot and end up with an injury like so. Back then, amputation was the treatment. There are conflicting studies in the literature. Some say that this is a relatively uncommon injury, accounting for less than 1% of all fracture dislocations of the foot. Others, not so much. They say that this is the most commonly misdiagnosed injury of the foot. And I agree. I see this at least once a month in my clinic, 4 to 6 weeks after an injury. X-rays were negative, and it's most likely a Lisfranc sprain or possibly a non-displaced fracture. And this makes up approximately 4 to 5% of professional football injuries annually. Darren McFadden, Maurice Jones-Drew, Santonio Holmes are all at the peak of their respective positions in the NFL prior to having the Lisfranc injuries. As you can see now, those of you that play fantasy football know that those guys are terrible now. So it's a big difference. And Jerry Jones is really taking a risk with this guy this year. So we'll see how that pans out for him. Lisfranc mechanism of injury relies on 2 main forces: a fixed forefoot plantar flexion and a forefoot abduction. I'm going to show you guys some examples of how this injury actually happens. As you can see, you're getting a dorsal displacement of the injury. It can happen planarly. It's rare because of the ligaments on the top are much weaker than the ones on the bottom. It's likely to displace dorsally. So what happens? This is something that is very important, and this is not a diagnosis to miss because of the post-operative or the post-treatment sequela is so damning with this type of injury. So the dorsal ligaments, they're the weakest group. As you can see, there's no attachment between the first and second metatarsal base. This ligament that I'm pointing to is actually called the Lisfranc ligament. It's the strongest dorsal ligament that connects the medial cuneiform and the second metatarsal base. So when you see a Lisfranc fracture or dislocation, you're always going to see diastasis or separation between the first and second metatarsal. The plantar tarsal metatarsal ligaments, they are stronger than the dorsal one, so it's very rare you're going to see a plantar dislocation, but it does happen. In the non-athlete, this is most commonly seen in a car accident where you're slamming on your brake before you're about to hit something, is when you see this type of injury. And then lastly is the interosseous ligaments. Those are the strongest ligaments together, and again, there's no interosseous ligament between the first and second metatarsal base, so you do have that separation there with that injury. Some more anatomy. If you look, this is a very, very tight, compact structure. The second metatarsal base is recessed within the three cuneiforms. This is extremely stable. So to have an injury in this area requires a significant amount of force. Physical examination. Edema, plantar midfoot or Mondor sign. Marked tenderness with palpation overlying the tarsal metatarsal joint and possibly excessive range of motion. This was a patient that we had, an MMA fighter who had a complete dislocation of metatarsals 1 through 5 laterally. So it happens, and they're not always this obvious. Some other key physical exam findings, the piano key test. It's when you grasp the toes and perform passive dorsiflexion and plantar flexion. Extensively stresses the midfoot. Very sensitive, very specific test for a suspected Lisfranc injury. And lastly is the single heel raise test. Guys, a patient will walk up against the wall and go up on their heel on the affected foot. Is also a very good test to determine if there's any abnormality of the Lisfranc ligament. Radiographic evaluation, like we talked about. Separation between the first and second ligament, or the first and second metatarsal. You'll sometimes see a little flex sign, which is an avulsion fracture off the medial portion of the second metatarsal base from the Lisfranc ligament. You'll oftentimes see dorsal displacement of the metatarsal fractures. If you don't see any type of fracture, and it's very common you're not going to see a fracture, advanced imaging is imperative, whether it be a CT scan or an MRI. Surgical treatment, closed reduction, like we did for the MMA fighter. It's very rare that you're going to come with an injury that you can actually just close reduce and everything's going to be fine. Usually it requires some form of an open reduction internal fixation, and I tell you the most common complication that you see postoperatively is post-traumatic arthritis. So in my non-athlete who doesn't have a significant dislocation and it's pretty well aligned but there's multiple comminuted fractures along the midfoot, I cast immobilize and I tell them, hey, we'll put you in a custom functional orthotic and see how far you make it, because more times than not, you are going to need a primary arthrodesis or surgical fusion of the entire midfoot. So even with the open reduction in our athletes, chances are they will need to go back to surgery at some point and get a primary fusion done. Post-op rehab, 0 to 6 weeks, strict non-weight bearing. 6 to 8 weeks, we progress them into a cam boot. At the very end of the 8 weeks is when I typically initiate my range of motion exercises. You're looking at 16 to 20 weeks and about 4 to 5 months to completely recover from this injury. It is very, very serious, and the post-operative complications that are associated with this injury are tremendous. Probably one of the worst injuries to have in the foot or ankle outside of a calcaneal fracture. And lastly, turf toe, first metatarsal phalange joint hyperextension. It's caused by a sudden hyperextension of the first metatarsal phalange joint, resulting in a sprain of the plantar plate. Most commonly seen in football, soccer, or baseball due to the artificial turf being much harder than natural grass and having much less give. Like I said, turf toe mechanism of injury. Forefoot is in a fixed plantar flex position, and a direct or indirect force pushes the first metatarsal phalange joint, damaging the plantar plate. Why does it occur less commonly in basketball as opposed to football and soccer? Well, I think a lot of it has to do with shoe gear. You look at the football players' cleats back in the 80s versus today, there's a substantial difference. They don't have the support, they don't have the, they're much more flexible, they're much less durable, making you more susceptible to that injury. Here's some anatomy. The plantar plate is that thick band of tissue that connects the plantar surface of the first metatarsal head to the base of the proximal phalanx. The sesamoids are the two bones here that are naturally occurring that assist in the gliding function of the great toe joint. You got to think when you're walking or you're running, propulsion comes from that great toe joint. So any violation of that is going to be costly. This is the injury that ruined Deion Sanders' career, turf toe. Physical examination. We use a Lockman test. Basically, you stabilize the proximal metatarsal and you go up and in a down direction with the digit. And with an intact plantar plate, you should not get much dorsal excursion. With a violated plantar plate, you're going to see a subtle or complete dislocation of that particular great toe. Physical examination, obviously bruising or edema in the acute injury, point tenderness. It's important to assess flexion of the great toe in order to assess if you've got a concomitant flexor tendon injury or the like. Radiographically, you're going to see a proximal migration of the sesamoids compared to the contralateral foot. I'm a huge proponent of getting contralateral films in order to compare subtle injuries that you may find on the x-ray. And obviously, if you do see this and a patient does have marked instability of the great toe joint, an MRI is warranted. Classification system, very big degree of difference in this type of injury. From a patient being taped on the sideline and going back in the very next play to being out 10 to 16 weeks with a complex reconstruction of the plantar plate, associated tendon injury, as well as potential sesamoidal fracture repair or removal. So treatment, taping and padding, custom orthotics with a Morton's extension. That right there will limit the range of motion at the great toe joint to allow a patient to return to activity. Cam walker and rest ice compress elevate. Surgical treatment. If it does get to that point where a patient has failed immobilization and has failed physical therapy, we do take these patients to surgery. The red arrow is the thick plantar plate, which you can see the obvious rupture. Here you can visualize the flexor lucis longus tendon to make sure that there's no associated tear or rupture of that tendon. And back here is the sesamoid, and you evaluate the intersesamoidal ligament to make sure there's no instability postoperatively. So, treatment protocols. I am a huge proponent of evidence-based medicine. If you practice evidence-based medicine, you are going to get predictable and most oftentimes favorable postoperative outcomes. I use a 3-stage approach: acute or protection phase, the subacute rehab phase, and then the advanced rehab phase. The first is the acute. The goal is to protect the injury, decrease pain and swelling. We do this by protection, by initiating range of motion, and by controlling edema or swelling. And the subacute rehab phase is initiated once the pain and swelling is resolved and the athlete is comfortably ambulating without pain. The goal of this is to increase strength and function, improve cardiovascular status, and promote neuromuscular and proprioceptive functioning through strengthening stationary elliptical trainers and balance boards and aqua aerobic therapy. Lastly is the advanced rehab phase. This is once the athlete is able to run, jog, and jump in repetition without pain, discomfort, difficulty, or swelling. The goal now is to return to the sport. So functional and sport-specific exercises are instrumental in this phase of rehab. The therapists that are in Lake Charles that I use are fantastic in initiating these 3 treatment protocols that I use. And it's worked wonders. I mean, you see a very predictable postoperative outcome. So when patients say, "Doc, how long does this take to recover?" you're able to say 12 to 16 weeks is what we're looking at. And if we vary from that, then we know either one, conservative treatment is failing and you may need more aggressive therapy, or something else is going on, or you can contribute sometimes it's due to compliance. So as long as you have these evidence-based parameters that show this is the time it takes to heal, then you should be on the right pace. So what does the evidence say? What does the literature say? Well, once an athlete suffers an ankle sprain, up to 80%, 8 out of 10 athletes can still suffer from recurrent sprains, and up to 72% may develop recurring symptoms of chronic instability. Average recovery times. That is the most common question we get. Doc, you gave me a diagnosis. When am I going to be back? Studies published in 1990 by Dr. Hopkins et al. And then verified by Dr. Gerber et al. In 1998. The average recovery time for a lateral ankle sprain, second and third degree, 28 days, 4 weeks. The average recovery time for a high ankle sprain, non-surgical, 55 days or 8 weeks. After 6 months, 38% of athletes that returned to play still reported signs of instability following injury. So that just goes to show that the high ankle sprain is a very, very difficult injury to treat non-operatively. And lastly is a psychological factor. You know, this is a direct excerpt taken from this study that was published in 2006. Studies suggest up to 19% of athletes experience psychological distress levels when recovering from an injury. These levels are much the same as a patient receiving treatment for mental health illness. This is something that you guys are more likely going to see than the actual surgeon or physician, because you're spending so much more time with them in the post-operative recovery. And it's important to just keep this in the back of your mind. You know, is this patient hesitant? Does he not want to participate in the drills even though he's pain-free? These are something to keep in mind. I think one of the greatest examples that brought this to the forefront in recent memory was the Bulls, Derrick Rose, for the Chicago Bulls. Cleared by a surgeon, cleared by trainers, cleared by physical therapists, just couldn't get with it. Forced into early activity, got re-injured 19 games into the following season. Sports psychologist on board. Almost every NFL and NBA team now has a sports psychologist as part of the rehab process. So this is something to just keep in mind, because again, it's something that I try to look for, but again, my time with the patient post-operatively is usually down to 10 or 15 minutes. I'm not spending nearly as much time with you guys or with these patients as y'all are post-operatively. I mean, you guys get to know these patients' families, you guys talk. So this is something to definitely keep in mind when you are treating an athletic patient. And lastly, having a multidisciplinary approach, I think, is the way of the future. You know, everybody tries to compare themselves to these elite or professional modules that they utilize. And sometimes in the local communities it's tough, but physicians and surgeons, physical therapists, trainers, psychologists, dietitians and nutritionists, coaching staff, athletes, parents, family, everybody kind of needs to be on the same page. And I think if we strive towards that, our sports patients are going to have a tremendous amount of relief moving forward. And that is it. Thank you very much.